This is an important part of the agenda this morning, and I'm really pleased to be joined by many colleagues. Also pleased to be joined by people who are watching online, and we can already see some activity online, Twitter, etc. So please remember to keep your questions coming in through that format as well. My name is Claire Harrison. I'm a consultant at Guy's and St Thomas's. To my right is Dr. Stefan Koschnieder. He comes from Aachen in Germany. Next to him is Ruben Messer, who's now from UTC in San Antonio in Texas. Then Professor Alessandro Vernucci from Florence in Italy. Teresa, who is a clinical nurse specialist from Bath. We've already heard a lovely presentation from her today. Professor Barboui from Bergamo in Italy, and Professor McMullen, you also already heard from Belfast. So, Nona, back to you.
Thank you, and thank you all for giving your time. Can I just remind the boundaries here? The team here are willing to answer any generalized questions, but can't answer personal treatment questions. So I would first of all like to open the questions to the floor. Could we have a question, please?
We could use an online question.
What? Has anyone got we have a question here. Yeah.
Yes, please. It's about thrombosis. How would we recognize that we have a problem with thrombosis?
Professor Barboui, I think you should take that one.
We have some criteria to recognize whether a patient is prone to thrombosis. The first is the age of the patient. As you know, thrombosis, arterial, venous, is a risk factor for thrombosis, first. The second is the history, the previous history. If in your history you had already a vascular problem, you have a risk of recurrences.
That's great. Tiziano, thank you so much. And just about clinical recognition of a thrombosis, how would one know if one had one? So how would you know if you had a deep vein thrombosis, for example?
Yes, of course. A doctor knows very well what to do when a patient has a suspicion of venous thrombosis. Generally, we do echo Doppler, just to say whether the thrombosis is under or in the superior part of the leg. That is very important, because if a venous thrombosis is in higher position, the risk of having pulmonary embolism is quite elevated.
Thank you.
Okay.
Perhaps to add in, and first let me give my thanks to Nona and John for the opportunity to be here. This is a wonderful meeting, and it's really very rewarding for us to have a chance to interact with each of you. I think frequently as MPN patients, you sometimes can feel that you have to almost act as your own doctor, in terms of trying to ward whether or not you have an event such as thrombosis. I think the key is when you have a disease like an MPN is to realize that you're at risk of unexpected things happening. So if you have unexpected symptoms, in particular unexpected leg swelling, pain anywhere, shortness of breath that's unexpected, any of these sorts of things could potentially be clues. I think when you're not feeling well, it's important having an MPN that you be evaluated by your primary care doctor or your hematologist to make sure nothing untoward has happened. There are some scenarios in particular where we are more prone to developing blood clots, prolonged travel without mobility. So I advise all patients it's probably wise to, on long flights, to get up every hour or two, drink plenty of water, or if we have certain types of surgical procedures such as a knee replacement, hip replacement, and others. So it's something to be mindful of, but never feel that you really have to diagnose or be wary of these things yourselves. But if you have unexpected medical problems, always best with an MPN not to ignore any signs or symptoms.
Thank you very much.
One of the problems that is very, very much associated for future events, cardiovascular events, is if you have erythromelalgia, microvascular disturbances. In many analyses, multivariable analyses, these can be associated with arterial vascular problems, say, during life. So this is another alert, say, to
Thank
be
you
treated.
very much. Thank you. Could we have another question from the floor? We've got lots here.
Can I ask, sorry, what makes an MPN a cancer, and what makes it a malignant cancer? And are there such things as non-malignant cancers?
So, Stefan, do you want to answer that?
Sure. I think I would also like to express my thanks to Claire and the organizers. This is a fantastic meeting. We have similar meetings in Germany, but certainly not that big. So I think it's a very tricky question that you're posing. The term cancer is certainly avoided by calling these diseases neoplasms. But on the other hand, an ET or a PV was called disorder before not so long. So the term neoplasm in myeloproliferative neoplasm really refers to the clonal nature. That means that we now know that these diseases come from one hematopoietic, so blood cancer stem cell or blood stem cell evolving into this chronic disease. However, we really try to avoid the term cancer because that is connoted with totally different things. We don't talk about metastases because these cells are everywhere in the body anyway, and so this is a functional term which means that that this comes from one cell and has evolved, but it by no means has anything to do with prognosis or anything like that, because that is very variable in these different kinds of diseases.
Thank you. I'd just like to ask the panel a question that's come in from online, and at the same time as saying that, please keep your questions coming in online. We will get back to you. We may not have the opportunity to answer every single question today, but I can assure you everyone who answers a question will get an answer. The question here is, I have ET-JAK2 and I'm curious if there's any connection with MPNs and hemochromatosis, also if there could be an inherited predisposition to MPNs. P.S. Family history of hemochromatosis, and also now looking back, some deceased family members had treatments very similar to mine 15 to 20 years ago.
Okay, so Mary Frances?
So hemochromatosis is an inherited disorder, something that the person is born with, where they have a genetic change, which means that they absorb too much iron. So it's entirely different from the myeloproliferative neoplasms, which are acquired disorders. It's something that people are born with. However, in certain populations, particularly in Celtic races, the hemochromatosis gene is very, very common in the population. Not all the people, even who have two wrong copies of the gene, go on to get iron overload, which is what happens with hemochromatosis. So I don't think anybody has really looked at the incidence of the hemochromatosis gene in the myeloproliferative populations. Interestingly, we did a very small study on people with erythrocytosis who were being investigated for erythrocytosis and found that heterozygotes for the gene were more common than one would expect. But the issue is that if you looked at a population with proliferative neoplasm, you will probably find the hemochromatosis gene quite commonly, partly because it is very common in populations. But the two disorders are entirely different, but it might be worth looking at a large population further. And then the family history is, with hemochromatosis, you very often have a family history of the hemochromatosis.
Professor Harrison, you wanted to comment.
I just wondered if, Alessandra, you might want to chime in on the question also about familial MPN?
Yes, we actually know that there is an increased risk of having an MPN if one of your family relatives is affected by an MPN. So this is a general population risk that is about 7-fold higher than in the population of persons who do not have a relative with an MPN. We now know that there are some genetic variants that are not mutations. These are changes in a small piece of our DNA that are common in the population, that are shared in the population, and some of these variants seems to predispose to the development of an MPN. But I have to say that this is research. It has no clinical utility. There is no reason to search for these genetic variants in you or your family relatives, in your children, because they are so common in the general population that it makes no sense and provide no information at all.
Thank you very much. Could we take another question from the floor? Okay,
Could I ask, what is CalR deleted, CalR positive? What is CalR?
Alessandro, I think that might be you again, actually.
Well, my pleasure. CalR is a protein, is the name of a gene that encodes for a protein that is called Calreticulin. Calreticulin is a protein that is present in any cells, in virtually any cells of our body. We had no idea of how it might work for the production of blood cells until it was discovered as being a mutated protein in about 20-25% of patients with essential thrombocythemia and primary myelofibrosis. It has been found in only a very, very few number of patients with polycythemia vera, and we usually assume that the Calreticulin mutation, CalR mutation, is only for patients with ET and myelofibrosis. So we have no clear idea, not 100% clear idea about how the mutated Calreticulin protein works, but for sure it works in a similar way as to the JAK2 mutation in priming cells of the bone marrow to grow without control, as it is typical for MPNs. There are two main types of Calreticulin mutation, so the gene may be deleted. That means that a part of the gene, a number of small pieces of the DNA are lost, and this is called type 1 mutation, and the second one is type 2 mutation, that means an insertion of 5 base pair in the gene. So there is a new piece of DNA that comes into the gene. So the end product is the same, the mutated Calreticulin protein. There might be slightly difference, and I think that I will touch this point during my presentation. There might be slight difference in terms of behavior of patients with deletion or insertion of Calreticulin mutation.
Thank you very much. Teresa, would you like to add from a nurse's perspective?
Yes, I mean, I find that I'm often sat in a clinic room and we're giving an awful lot of information, and you can see that patients are becoming quite sort of almost blank with all the information that we are providing. And what I always try and do is just try and explain afterwards what all of these things mean, and how it provides us with more information about your condition. It provides us with more prognostic information, and I always try and just come in and explain all of that. But it's very important that perhaps once you've had your diagnosis and when you've got used to the idea of what's going on and possibly started treatment, that we then can go back and go through in more detail exactly what these things mean. But it can be quite overwhelming at the start with all these things mentioned. Thank you.
Thank you. Could we have another question, please?
Yes. MPNs are rare diseases, and fortunately in the last 10 years there's been rapid expansion of understanding new treatment opportunities. But if you go to your GP, they may have heard of PV, but they'll refer to you to a specialist. If you go to a specialist, so you go to a hematologist, they may not have that as a specialism. They may be very aware of it, but it's not their specialism. So should you be asking your specialist on a scale of 0 to 10 how up-to-date and comfortable they are in treating patients with MPNs? And a question to those that are in that position, to be the haematologist, would you be offended if the patient asked you that question?
Maybe I should take that one. Yeah, so I think you should always be honest with your clinician, and you should find a clinical team that you have a trusting relationship with. I think you should, however, also trust in the professionalism of your healthcare team. If you are under a clinician who did not feel comfortable with managing a patient with PV or ET, they generally will move you to someone else in their team. In Bath, the clinicians, for example, tend to subspecialise. Haematology is a massive disorder. There are more than 36 different hematological cancers or neoplasms. So in general, we do only practice within our area of expertise. Of course, there are people like myself and others sitting along here who only, in general, manage patients with MPN. But even then, I treat patients with other conditions too. So your haematologist probably does manage other disorders. Of course, they probably do. Mary Frances treats leukemia, so does Alessandro, etc. I think you should be comfortable in asking your clinician, but perhaps also trust in their professionalism.
Thank you. We've got time for, yes, another. Okay.
I'm interested in nutrition and how that might affect MPNs. I understand Professor Meese is involved in research in that, and I wondered what stage that, if there's anything to report there.
So it's an excellent question. Certainly MPNs, are chronic illnesses that affect people for many years, and the rest of the health of the individual, is clearly very important. Clearly, an individual is never one disease. One's health has many contributors, including your baseline health, your fitness, as well as implications of an MPN. So when it comes to nutrition, I'd say that there are several components. One, without question, we've learned that the importance of trying to maintain good cardiovascular health, as it is for the general population, is particularly important for patients with MPNs. So issues such as cholesterol, sodium, physical activity, all of these things are very important, and probably even more so in individuals with MPNs. Now, the second question, is there anything specific we should be doing different in terms of nutrition that could further help MPNs through decreasing inflammation, through helping with symptoms, or other aspects? At the moment, I'd say that we don't know for certain whether there's a specific recommendation we should follow. But it is something that we are very much going to be studying. And that, again, if you think about all of the aspects of how important our nutrition can be in terms of how we feel, there's a lot of evidence to suggest, that what you eat might have a lot of implications in terms of how you feel with a disease like MPNs. So we are going to be doing some studies. I'll be covering a little bit in my talk later. But there are many types of approaches people have taken. Is it gluten-free? Is it anti-inflammatory? Is it a paleo diet? Is it the Mediterranean diet? So many different discussions, and we hope to bring a little bit of science to it to study some of these different options, as well as see what the implications are.
Thank you. A question from the back?
Is there any difference between primary and secondary myelofibrosis, and how do you tell the difference?
Okay, Alessandro, would you like to answer that question?
Yes, the terms primary myelofibrosis refers to the appearance of the disease in a person that has no prior history of another disease, particularly polycythemia vera and essential thrombocythemia. In this case, myelofibrosis comes as an evolution of the polycythemia vera, for example, and so it is called post-polycythemia vera myelofibrosis, or also secondary form of myelofibrosis. So till now, the two entities have been considered quite similar, and indeed they are quite similar under several respects. We are now starting, but this is largely still science, not yet clinical, does not have yet clinical implication. We are starting to make some differentiation between primary and secondary forms of myelofibrosis. But again, many of the clinical issues are similar, and the way we deal with this, we manage these disorders is quite similar.
Thank you.
I belong to a Facebook group on interferon patient users, and a lot of people there claim to be on remission. I was wondering what your experience is of achieving remission or completely stopping the progression of MPNs when using interferons such as Pegasus.
Yes, very good question. So interferon is a very specific drug since it's not targeting inflammation to inhibit inflammation, but it actually causes some kind of inflammation, or let's say patient response against the cells. So there's a lot of hope that we can push back the disease rather than just slowing the growth of these cells. There have been clinical trials showing that interferon or pegylated interferon can be very effective, even as effective as in very few patients where we had to discontinue the interferon because of bad tolerance of the drug after a while. We saw that the disease hasn't come back, but that's really very rare. And so we're still at the beginning of understanding what interferon does to the disease itself. We do have a problem, at least in Germany, that interferon is not yet, I would say, approved. And so in Germany we have to have special arrangements, ask the care providers, the insurance companies to allow us to use it. But it's, I think, a very promising drug, and there may be a new interferon coming, which is then approved and which we can use for PV, possibly also for ET, and maybe for early myelofibrosis.
Thank you. Okay, so I think Ruben also will cover that this afternoon, so you probably will hear more on that topic this afternoon. No?
Can I just take another online question that's come in? It says, many of us take hydroxycarbamide for our MPNs, especially PV. What are the latest views on risks of additional cancers acquired as a result of this treatment?
Ruben, maybe you want to take that one?
Sure. So, in long-lived diseases with MPNs, it's sometimes difficult to sort out what contribution taking a particular drug is for developing secondary cancers, because people live for many years, and we know as we age, we develop cancers. I would say that the clearest data is unequivocally hydroxycarbamide is associated with an increase in skin cancers. That, I think, is probably indisputable. That is increased in people that have been exposed to for lengthy amounts of time to hydroxycarbamide, particularly the non-melanoma type skin cancers. Now, the greatest controversy is whether hydroxycarbamide really accelerates the progression of MPNs to acute leukemia. That's both the greatest concern as well as the area of least clarity. Through some of the long-term efforts of, in particular, Professor Barboui and his colleagues in Italy that have done some very nice prospective studies in polycythemia vera, it's not clear that hydroxycarbamide alone in individuals that have taken MPNs clearly raises the likelihood of progression to acute leukemia. By the flip side, it's impossible to say that there is zero risk of taking hydroxycarbamide either. So what I share with my patients is that I view that there may be a risk. I do not view that that risk is significant, but I can't say that I can completely say that it is zero either. I do think the risk of cutaneous cancers is real, and I certainly advise patients who take hydroxycarbamide to be in particular very sensitive to their sun exposure, use appropriate sunscreens and things of that nature, and that I think that largely is not sufficiently discussed.
Okay, thank you so much. And actually, I know that Tiziano, Mary Frances, Alessandra and myself will shortly be starting a study looking at cancer after MPN. But I think we also have to think about lifestyle issues here. Tiziano, you said don't smoke. Smoking is also a massive risk factor for cancer too. We also have seen some skin cancers in patients with ruxolitinib. And last point is that actually, in looking at the Swedish data, of the patients with MPN that particularly develop leukemia, around 1 in 4 of those patients have never had an MPN treatment. So leukemia is not always a treatment effect.
Thank you very much. Sadly, we've now run out of time. Maz is signalling to me from the back. But I think, and I'm aware that there are a lot of people with questions in the audience still, and online questions coming in. We're due to break for coffee, but do you think we could take one more question from the floor? Would everybody mind just waiting 5 minutes for coffee if we took one more question to this international panel? Okay. Could we have a question, please?
Sorry. Me? Yeah. Currently, I think it's great to have the various options we do have for treating the MPN, but it is very limited. But there's a lot of research going on. Where do you think we'll be in 5 years from now? What do you think are the most promising options looking ahead in the next 5 years?
That's a wonderful question.
That's a wonderful question. I kind of wish I would like to have like a 20-second soundbite from every panel member, actually. Mary Frances is going to come to you first.
There are a number of treatments in trials or coming to trials. We have seen some fall and not get through, but I think in the next 5 years there will be more treatments. I mean, Ruben talked yesterday about various treatments, and some of these, I think in 5 years there will be a number of more drugs through to license.
Okay, you're hedging your bets.
Yeah.
Professor Barboui, what do you think might be the most exciting thing in the next 5 years? Tiziano, what is your idea of...
I think in the next years, what we should do, we have to describe the natural history again of these diseases. The criteria for diagnosis are changing. Maybe we have a population in the next years of patients diagnosed very early. So we don't know really whether the natural history of these patients is similar to the general history we saw some years ago. Take, for example, the rate of thrombosis, just to talk about thrombosis. If you consider the population until 2005 and the population after 2005 means JAK2. JAK2 that is able to distinguish between the disease versus no disease in polycythemia vera, for instance. Well, the rate of thrombosis is declining very, very much because we anticipated very much a diagnosis of the disease. So the panorama can change in relation to the new criteria of these diseases.
So better definition of natural history, I think that's really important. That resonates with a lot of us. Teresa, any quick thoughts from you?
Yes, I think it's really important that the smaller hospitals engage in clinical trials because at the moment the way we see it across haematology is there are a lot of new drugs coming in, some of the other conditions we look after, and we don't have access to them unless we engage in a clinical trial or somebody pays for them privately. So I think it's just really important that you badger the smaller hospitals to engage in the clinical trials, and therefore you will have access to drugs. It's a shame it's like that, but that's the nature of things at the moment.
Yeah. So I think we've been working really hard on doing that in the UK, and for example, the MAGIC study is open in 40 hospitals, and that's really, really important. Great point. Alessandro, coming to you, quick soundbite.
Well, I'm quite confident that in the next 5 years we might be able to use the methods of personalized medicine also in MPNs. That means that by understanding better what is the genetic basis in a very broad understanding of the term, the genetic basis of these disorders, we might have clear idea about the characteristics of a patient, the evolution of the disease, and to start choosing the treatment based on these characteristics, the individual characteristics, more than on general course of patients as we are doing right now.
I probably would even build on Alessandro's characterization that in 5 years, I think really the matching of a treatment for you will be much more precise, not only in terms of genetic terms, but in terms of other aspects of your health, your symptom burden, and disease characteristics. Both with our current therapies, there are individuals that have great responses to any of our current drugs, but clearly not all, as well as new drugs. So I think the concept of really much more individualized matching of therapy will really, I think, advance us greatly.
Great, and Stefan.
Yes. So given the great achievements during the last 5 and 10 years that were really pushing the whole field and knowledge forward, I think we can expect very good progress during the next 5 years. I see it in 3 areas: better understanding of the nature of these different diseases, and then better diagnostics and prognostics tools, meaning how will an individual patient do probably, and then more individualized therapies. I agree with that.
I would like to say, and on behalf of us all, a huge thank you to all of you.